Good evening, everybody, and welcome to another edition of In Conversation Live from the Royal Society of Medicine. You're very welcome. Tonight, we've got a very special guest, Sir Richard Brooke Sykes, Fellow of the Royal Society and Chairman of the Royal Institution. I'm going to read out some information about him because there's quite a lot of interesting background. Hi there, Richard. Great to see you. A lot of interesting background, and that I think will help you formulate your questions. Do send your questions in. We'll try and get through as many as we can during the hour. So Sir Richard he chairs the advisory board of King Edward VII Hospital and the UK Stem Cell Foundation. He was named in 2021 the UK government chair of the vaccine task force. So you could call him Sir Richard, the booster vaccine czar, I guess. He's a Yorkshireman, that's very important. And he was educated at Queen Elizabeth College, where he graduated with a BSc in microbiology and then went on to do a PhD in Bristol. And there he started his work on beta lactamases. And he's probably famous for all sorts of things, but very famous for that role in discovering whole new range of antibiotics, which were potent across a range of bacteria, particularly the gram-negative bacteria. Until 2002, he was chairman of GlaxoSmithKline. Before that, he'd been CEO, and he's rector of Imperial College London between 2001 and 2008. And as we were just discussing, that wasn't without controversy, because Richard had the idea to merge Imperial College and University College London. And there was some opposition, mainly from the people in the arts departments, I think. He also was linked to the argument about raising tuition fees for students. And long before it actually happened in 2011, I think Richard realized that a £3,000 a year for a university degree was too low. Now, I think he suggested £10,000, but of course that was controversial. He's been involved with the Natural History Museum and the Royal Botanic Gardens in Kew, and he also was appointed chair of NHS London, but there, again, another controversy, because he resigned when the Cameron government called a halt to what sounded to me like very sensible reorganization across healthcare in London. We can discuss that. And finally, he was credited with the Saving the Royal Institution, founded in 1799. So saving that is rather important for our heritage here in London. So Richard, I often say this is a bit like Desert Island Discs without the music. So let's go right back to your Yorkshire roots, Huddersfield, I think. Tell us a little bit about your childhood.
Okay, so I was born in west of Huddersfield, actually, called Slowett or Slaithwaite, which is just on the edge of the Pennines, going into Lancashire, about 8 miles west of Huddersfield. And I went to the local C of E school, passed my 11 plus, went to grammar school, to Royds Hall Grammar School, where Harold Wilson was educated.
All right.
And from there, funnily enough, when I'd taken my O-levels, I was never good at school, to be honest with you, not really interested, but my mother was very ambitious. And so she knew the local pathologist, and she got me a job at the Huddersfield Royal Infirmary in the pathology department. And, you know, funnily enough, within a few weeks, I knew exactly what I wanted to do in life. I just loved it. I just loved everything about pathology. The legs in buckets, the bacteria, the hematology, the biochemistry, just amazing. So I took all my exams for the Institute of Medical Laboratory Technology before I ever went off to university, which of course was a great thing, because that helped tremendously.
Were your mum and dad scientists, or what sort of background did you grow up in? I mean, were they well off Yorkshire people, or?
No. My father was a carpenter, but he kept a small holding, so we always had lots of animals around. We had a little farm, and my mother never worked. I mean, she just looked after the family.
Yeah. So were you the first one to go to university from your family, really, or?
Yes.
Yeah. Interesting. And then the university was in London, Queen Elizabeth College, right? Is that right?
Yeah,
Is that where it is?
I went from so at the Huddersfield Royal Infirmary. I did my exams there, and then I went off to Westminster Medical School to work for a guy called Brian Lacey, who was the guy who actually did all the work on Bordetella pertussis, whooping cough vaccine. And so I worked with him for 3 years in Westminster Medical School. And then he was the one who said, look, you don't do medicine. Don't bother about medicine. It's too complicated. Just go and do microbiology. And he said, you need to go to Queen Elizabeth College because there's a man there who's just come back from Rome with Chain. Chain came back from Rome at the same time. They both worked in the institute in Rome. And he said, you should go to Queen Elizabeth College because that's the perfect place to study microbiology. So that's why I went there.
Right. And then Bristol and that work, the PhD on beta lactamases. I mean, just because we get a lot of non-medics watching these things, just explain the beta lactamase story in there, Richard, for us.
Okay, so I was always interested in antibiotics and antibiotic resistance because remember when penicillin was discovered, it didn't take long to find out that there were enzymes that could destroy penicillin. And penicillins and cephalosporins, all those families are called beta-lactam antibiotics because they contain a beta-lactam ring, a 4-membered ring within the structure of the antibiotic, which is crucial to their ability to kill bacteria. And so what happens in nature is there are enzymes in the soil, because many of these antibiotics come from the soil. There are enzymes that will destroy the antibiotic to protect the organisms in the soil. And these enzymes are called beta-lactamases because they destroy the beta-lactam ring in penicillin, for example. So by 1995, by 1955, just to give you an example, 95% of all staphylococci isolated in London hospitals were resistant to penicillin. That's how bad it was in the mid-50s. Because of that problem. And so, from then on, there was a real drive to find antibiotics that could resist these beta-lactamases. Initially, big problem in staphylococci, but by the time I came along, it was becoming a big problem in gram-negative bacteria, and particularly in Pseudomonas, in Burns units. These things were a nightmare, and they were destroying the antibiotics that were used to treat the infections.
Yeah. I mean, that gives me a chance to give a plug for Sally Davis, who's now master of Trinity College and very famous former chief medical officer. She's helping us run a program on antimicrobial resistance. The RSM is running on the 23rd of November, so put that in your diary. So how did the work you did there and the PhD, did that lead you to go and work for GlaxoSmithKline, or was there something else in between that, Richard?
So, and again, it just shows you what was happening those days. So we're going back to the 60s now. And I, when I finished my degree, I was awarded a CAPS studentship through the Science Research Council. And that was a cooperative award in pure science. And what it meant was that I could go to Bristol University, and Glaxo, who were the co-sponsor in this award, would pay half my salary, if you like, or my fees, and I would go to Glaxo at least once or twice a year and get involved with the company. And that was brilliant because my supervisor, Mark Richmond, had come from Edinburgh. He'd come to Bristol. He was interested in beta-lactamases because he was a methicillin man, basically, staphylococcal resistance to methicillin. And he wanted me to get involved with Pseudomonas and gram-negative bacteria. And so he was the one working with Glaxo. He said, look, I'll set up this scholarship. You come, and then you get involved with Glaxo. But the problem is, after a number of years, Glaxo kept wanting me to go and work at Glaxo. And I said, absolutely no way, because I've seen how you behave. I've seen what you do. And I prefer probably to stay at Bristol. But eventually, it became clear that I'd be better off in industry than I would in university. So eventually I went to Glaxo to 1972 to be head of their antibiotic research unit.
Uh-huh. And is that where the main discoveries took place that you're involved in Glaxo? Or?
So during that time, the antibiotics were big business in the pharmaceutical industry. Beecham's, of course, discovered the nucleus of penicillin, which was 6-amino-penicillinic acid. From that, you could make semi-synthetic penicillins, so methicillin, flucloxacillin, cloxacillin, ampicillin, amoxicillin. All those antibiotics came out of that program for Beecham's. So Beecham's were driving that side of it. Glaxo were driving the cephalosporin side, because cephalosporins, which were discovered in Sardinia, came to Oxford, same old route. People in Oxford isolated the cephalosporins, worked with Glaxo, so Glaxo had access to all the cephalosporins. So again, Glaxo were driving the cephalosporin side, Beecham's were driving the penicillin side. So we developed a number of cephalosporins, but then in 1976, I was offered a big job in Princeton in New Jersey, and so I went there to the Scribb Institute of Medical Research.
Uh-huh. I got one question, which is, I mean, slightly off the subject, but it relates to the stem cells, because you're involved in stem cells. So Philip Gaskell, thanks Philip for this question. I've got a friend with Parkinson's who's having stem cell infusions regularly. Would you have those if you had Parkinson's? That's a bit of a technical question.
Well, you know, Parkinson's, like a lot of other these diseases, is basically a cell destruction disease. And so how are you going to deal with these diseases? By cell replacement therapy. So I think it makes a lot of sense. But the problem is we just haven't done enough clinical trials in these areas to understand about cell therapy and how that can work and what kind of cells you need to use. So that's why the Stem Cell Foundation was set up to actually fund clinical trials in these promising areas. So like spinal cord problems, there's one now in multiple sclerosis. So all these types of diseases certainly will, at the end of the day, succumb, in my opinion, to cell therapy.
Yeah. So before we leave Glaxo, I mean, there's a slight shadow over Glaxo reading the Financial Times weekend. That's how I get my financial information, by reading that. I don't read it during the week. But, you know, there are question marks over Glaxo's performance compared with, say, Pfizer or any of the big American outfits. So, I mean, what are your thoughts about Glaxo right now in terms of its future as a pharmaceutical giant?
Yeah, these pharmaceutical companies go through phases. There's no question about that. I mean, Glaxo was a star, as you know. It was the biggest company in terms of capitalization on the FTSE in the 90s. And once we'd merged with Wellcome and made Glaxo Wellcome, and then we merged with SmithKline, you're talking about a big organization. And in the last sort of 15 years, say, it's fallen back to a situation now where it's probably, it is less capitalized than AstraZeneca, which would have been in the past much less than GlaxoSmithKline. So I think probably one of the biggest issues is that they missed out on the cancer drugs. They left that alone, went different direction. And of course, that's what's driven AstraZeneca forward, and Glaxo really hasn't moved very far forward in the last 15, 20 years.
I mean, we'll come on to the vaccine task force, but they were working on a vaccine for COVID, weren't they, Glaxo, in combination with a French company, but that didn't quite work out.
But if you think about what's happened in the vaccine world, so the great vaccine producers in the world are GSK, Sanofi, Merck, and if we relied on them to solve the problem of COVID, we'd still be waiting. I mean, it's quite remarkable that the people who've really come to the fore here are the small biotech companies, working again sometimes with big pharma. But it's those people that who've driven the science forward that have come up with the goods. And the great vaccine producers still waiting for them.
Yeah, it's really interesting. So let's go on to talk a little bit about London University and University College, well, Imperial and University College, because that must have been an interesting phase of your life there. It's not an easy scenario, is it, heading up a university? I mean, I was up at Cambridge last weekend and I was thinking, I mean, golly, trying to get all these colleges and the masters of the colleges and all the various tutors and deans and et cetera, organized. That isn't easy. How was it for you in London?
No, but I think it's fascinating because I could have, when I stepped down from GlaxoSmithKline, I could have gone and chaired other big industries. I was at Rio Tinto, for example. I was a senior independent director at Lonza. But to go and run a university like Imperial was an amazing challenge because, and it's a great management development tool. You should actually do it first before you go into industry, because you can't just tell people what to do. You have to negotiate with them. You've got to work with them. You've got to convince them this is what we need to do. And so, to be honest with you, I really enjoyed it. I didn't find it difficult at all. I thought it was absolutely fascinating. But Derek Roberts, remember, ran UCL for a long time. Derek retired. Then the Chris Llewellyn-Smith came in. And then he got fired. Poor old Derek was brought back. So Derek and I thought, well, wouldn't it be a great idea to put the two universities together and really create one of the best universities in the world? And of course, that we talked about it. We planned it out. We talked to various people. And to be honest with you, the scientists and the medics were quite interested. They were all on board. But there were fractions within UCL that were antagonistic. And at the end of the day, you know, they're universities, they have to go along with everybody. And so they had a Senate meeting and Senate voted against it at the end of the day. But it was interesting.
Was it a close vote or was it in the end, sort of overwhelming?
I don't think it matters, Roger, because unless you've got everybody on board, it's going to be difficult anyway, but you've got to take everybody with you. If you're not taking everybody with you, it's a pointless exercise.
Yeah. Well, I have experience of merging charities. In the end, we created Prostate Cancer UK by merging them together. But in order to get the charities to merge, you have to get one CEO to resign and half the trustees in both charities have to resign. So it's turkeys voting for Christmas, and it's not easy. But in the end, if you can pull it off, certainly Prostate Cancer UK has done really well. I'm proud of that. But then the other controversy that you're involved in is that student grants. That must have been, of course, old Nick Clegg he's getting a lot of flack from Facebook at the moment, but you were one of the first people to realize that student fees were much too low at £3,000 a year. Is that right? How did you get involved?
No. It started long before that. So a committee was set up that I sat on by the government, and it was during this transition period of 1997 when Labour were coming to power, but the Conservatives were still in power. And we had this committee set up to look at the whole concept of funding universities. And the answer was, and that Labour and the Conservatives would both agree to whatever came out of that committee, whoever came to power. And the recommendation was £1,000 for a student per year to go to university. Obviously, that was the recommendation. And then my job was really to try and convince Tony Blair, who now was the Prime Minister, that will not last. You cannot just charge £1,000, but you've got to create a market, because it is a market. You've got some universities that are as good as any universities in the world. You've got others that do completely different things and should not be of the same value. So therefore, if you create a market, you could charge 5,000 or you could charge 1,000. And some may say, we're only charging 500. But, you know, the next step was 3,000, but everybody charged 3,000. Every unit, 145 universities charged 3,000. And then, of course, all hell broke loose, and then it was 9,000, and 145 universities charged 9,000. That has no market there. There's no logic to that at all. So when you look at the way Cambridge and Oxford, for example, educate their students, and then you look at the University of wherever, it's like chalk and cheese. How can you charge £9,000 per student? It doesn't make any sense.
Yeah, it is a bit crazy. There's a question from Andrew McCutcheon, which takes us back to what we were saying about antibiotics. He says, how do you see the situation with antiviral drug development? Are there any substances found in nature that might be pursued or copied? I mean, of course, you know, in the era of COVID, and antiviral drugs that work would be really interesting, wouldn't they?
Yeah, and I think that's a very good question, because in nature, you know, viruses have been around for billions of years. And so you'd expect, because viruses infect everything. Bacteria have viruses, viruses have viruses, everything has viruses, plants have viruses. So you would imagine that the antivirals would have developed within that environment where viruses play a role. And of course, that happens in bacteria, because bacteriophages are viruses that affect bacteria. Bacteria have a way of dealing with those. And of course, that's where CRISPR-Cas9 comes from, because it's the ability of the bacteria to destroy the virus, to interfere with it. So there must be, but I don't think, to my knowledge, there's been a great push. Because if you remember, the whole golden era of antibiotic research was looking in the soil, looking at streptomyces, looking at fungi to see if you could find novel antibiotics. And that's where streptomycin came from, erythromycin. They all came out of soil microbes. But nobody looked for antivirals, in my opinion, in nature. They were all chemically derived. And that's the way it's gone. And now you look at the antivirals that are being developed for COVID, they're all chemically derived materials. And I think that's a very good question. If you could think of a way of setting up assays to look for antivirals in nature, I'm quite sure you will find them.
Yeah, no, and then I mean there are antivirals that are beginning to work in COVID, aren't there? That are reducing mortality, and I'm not an expert on them, but there are some quite promising signs. The combination of those plus the vaccine may be the way ahead, possibly.
Yeah, because like flu, coronavirus is an RNA. It's an RNA virus, and flu's an RNA virus. So molecules have been developed against flu, which basically interfere with the replication of RNA. So it's those, some of those molecules that are being used now. The Merck molecule, for example, was developed for influenza, but it's now being used for COVID. And then other ones are being developed against enzymes that COVID has in its replication system.
There's a comment really from Surendra Paul. Thanks, Surendra, about the increase in fees. He's saying that for international students, particularly in those in developing countries, the increase in fees led to a lot of hardship for students and their families. Any thought about that?
Well, of course, there's no cap on fees from students coming from outside the UK, and so universities have seen this as an amazing opportunity. And if you look at some universities now, they run on fees from overseas students, which can vary between 15 and 30,000. Yeah. So, you know, if you want to do medicine in the UK, even though we still limit it to 7% of the total intake, you can be charging 30,000 a year for those students. And even for engineering, you're charging 25,000 a year, which is an enormous amount of money for people to pay.
Yeah, absolutely right. And China, I think, is a massive source, isn't it? Of course, COVID has affected that because it affected university. Let's talk a little bit about the Royal Institution. There's some more interesting questions coming through. Actually, before we do that, Julie Russell says, what do you think about the GSK sale of antibiotic sites in the UK in terms of UK national security? Any thoughts about that?
Yeah, I mean, we're talking about Ulverston, basically, where a lot of... So the first penicillin ever produced in the UK came out of Barnard Castle, and Barnard Castle was set up, Ulverston was set up to produce the cephalosporins, Griseofulvin, most of the antibiotics, quite rightly, that has now been sold off. I think, the problem is many people dropped out of antibiotic research, as we all know, because it became a big issue of getting them approved, getting them used because of antibiotic resistance. So many of these companies that really spent 80% of their research budgets on antibiotic research now spend very little. And I think that is a problem, and it's true of all infectious diseases. I think before COVID, we'd taken our eye off the fact that infectious diseases are still one of the biggest killers in the world today. And we've become very blasé about that. And we've sort of let everything disappear. And then when something like COVID hits us, we start thinking, who's producing these vaccines? At least we got Oxford to do that through the Jenner Institute. But we didn't really have any real vaccine manufacturing in the UK, and that had to be put in quite quickly. And it's the same with antibiotics. So I do think it is something, we need that resilience to make sure that we're keeping on top of all this stuff. It's quite right.
Well, Trevor Jones just texted in a message. He says that in relation to coronavirus antivirals, we're preparing antivirals not just for COVID, but as a part of pandemic preparedness, and the UK is playing a major part in that. And that actually gives me a chance to plug for tomorrow. We've got Jeremy Hunt, Right Honourable Jeremy Hunt, on our lunchtime RSM webinar, and we'll be grilling him about the parliamentary committee's review of what's happened in COVID. So that should be really interesting. And Peter Wisniewski says universities in the UK are mostly a bargain compared to those here in the UK, in the USA. He must be listening from America. Hi, Peter. I mean, how much does it cost to go to Harvard or Yale, do you think, Richard? Any idea?
Well, of course, remember, they do have a lot of scholarships. So, and a lot of the brightest kids in the UK now are actually gravitating to some of these particularly the Ivy League universities, where they get full funding. So they're not actually paying that much. But, some students are paying $50,000 a year to go to a university in the US, quite right. So that is a serious issue. But if they want the really bright people, if you look at the endowment that Harvard has, you're talking about hundreds of millions, and they can afford to attract the brightest and the best from anywhere in the world and actually fund them to do their work. And that is different from the UK. Now, we do have universities that have some scholarships, but it's nothing compared to the United States.
Yeah, actually, a couple of interesting answers come in. Kevan says 40 to 60,000 per year for 4 years. Ouch. And somebody's just texted through saying 70,000 a year. Probably that is Harvard or Yale. So yeah, but probably the education in these big American universities is pretty fantastic, at least as good as Oxford, Cambridge, I imagine. So let's talk a little bit about the Royal Institution, because actually I was having lunch in the RSM today, and somebody came up and said, "Oh, I see you're interviewing Richard. He's the man that saved the Royal Institution." I mean, it was founded in 1799. I looked up on Wikipedia. So, how did you save the Royal Institution, Richard? Come on, tell us the inside story.
Well, the Royal Institution, you just have to understand the history of the Royal Institution. It was actually spun out of the Royal Society at a time when science was really moving forward. And so the idea was the public needed to be engaged. And they couldn't do that through the Royal Society because that's an academy, really. So why not have a body that could deal directly with the public and explain to the public and have lectures and have demonstrations to make sure that people understood what was going on? And so Humphrey Davy was the first director, and then, of course, Faraday took over. Faraday, the discoverer of the electric motor, and that's 200 years ago since that happened. And some great people, 14 Nobel Prize winners have come out of the Royal Institution over that period, because it was a place for doing research funded by philanthropy, basically, and giving lectures to children, to adults, about keeping them involved with science and how the public interact with science. So played an enormous role, and it got into trouble in the early 2000s by trying to spend a lot of money renovating the building without having that money to spend. And so a number of properties which brought an income into the RI and helped fund the research and keep it going to provide all these programs, particularly for children, dried up because there was no funding anymore, because all the properties had to be sold to pay off the debt. So when I got involved in 2012, there was a debt of about 7 million, and it was running at an operating deficit of about $1.5 million a year. So something had to be done quite quickly. Unfortunately, we started to rent out the facilities in the building like you do at the RSM. We managed then to get some money from philanthropists and eventually wiped out the debt, but that took a long time. That took about 7 years. And then we were turning over about 2 million a year from renting out the facilities, doing all the standard things. And of course, we were doing a great job until COVID hit. And now we're back in a difficult situation again, I would say, because we're just not getting the income coming in now because people aren't using the building the way they would have done before.
You're a fellow, you're an FRS. Actually, my dad was an FRS. I like to mention that, 'cause I'm proud of that. But just explain to people the difference between the Royal Society and the Royal Institution.
Well, the Royal Society, it again started back in the middle of the 17th century. But the Royal Society is an academic institution. It's an academy. You can only get elected to the Royal Society, and there are about 1,200 members of the Royal Society, elected fellows who have done, very, very good basic research.
Yeah.
Generally, the Royal Institution is a public institution. Anybody can become a member of the Royal Institution. So that's the whole point. It's a public body, and it's there to work with the public engagement, getting the public to understand about science. And of course, today there's wonderful things like maths masterclasses, computer masterclasses, engineering masterclasses all over the country for young children. So it's an amazing institution.
Yeah, I think I went to one when I was a kid, actually, I remember. And they do famous Christmas lectures, don't they? They got Van Tam this Christmas, I think.
Yes,
yeah. So I mean, Susan Greenfield got a lot of flack over that. I mean, would you say Baroness Greenfield was the root of the problem, or was it unfair with the way the media picked on her?
Well, remember, these institutions have a governing body, so you can never blame one person. There's a governing body that's supposed to be responsible for managing these great institutions, these public bodies. And so if anybody's to blame, it's the whole body, not just a person. But they spent a lot of money, 25 million, renovating the building. They didn't have 25 million, and they got into very serious debt.
Okay, there's a question about vaccine hesitancy. I think we'll leave that for a bit. Thanks, David. We haven't forgotten your question. We'll come back to that because we want to talk about the vaccine task force. But a couple of questions, one from Eliza Hyde and one from Andrew McCutcheon about pluripotential stem cells. A lot of interest in that. I mean, you mentioned, you think a lot of diseases in the longer term. I mean, I think the questions are people would like to understand a little bit more about pluripotential stem cells. Just give us a little background on that for the audience, Richard.
Well, if you think about it, we all start from a fertilized egg, don't we? So we take one cell and we fertilize it, and from that we develop. We all develop from a cell. remarkable. All the instructions for producing me and you and everybody else listening tonight comes after that. So these pluripotent stem cells can actually turn themselves into any cell. So we have cells, as you know, that set off to make cartilage, they make bone, they make nervous tissue, they make cardiac tissue, they make liver tissue. They're all there, all these cells, and eventually they all turn off, just like the fingers turn off, because otherwise, if the cells making the fingers kept growing, we'd have enormous fingers, but they know when to stop. And so this stop-start of the genes are controlled by amazing pathways that develop our organs as we grow and develop in the fetus and produce everything that we see. So these are pluripotent stem cells. You can turn them to do anything. They can make cardiac tissue, liver tissue, bone tissue, cartilage tissue, anything you like. So the potential is enormous, but it's controlling them. And we know that when they get out of control, then we get into serious trouble. So that's where people talk about these pluripotent stem cells, getting them in the right environment to produce the right kind of tissue that is required. So the potential, as I say, is quite enormous.
Yeah. Actually, I'm coming back to the issue of universities and funding and so on. Donald Nuss points out that Harvard's got 50 billion in its foundation, and recently criticized in the press because it was too conservatively invested and earning only 20% in the last year on its investment. So it's probably now got 20% of 50,000 it's an extra 15 billion on top of that. Yeah. Wow. I mean, I think American universities get the fundraising story much better than we do. And I mean, let's talk a little bit about that, because you are also chairman of the trustees of King Edward VII Hospital. We had the Queen in there for a day, famously in the press recently. I mean, that's a small hospital, but are you enjoying that role, Richard, at little old King Edward VII?
It's very different from being chairman of the Imperial NHS Trust, the NHS Trust. So at least in that small hospital, they strive for excellence. They do everything extremely well. It's a small hospital. It's got 60 beds, a turnover of maybe 40 million a year, but really high class and really strive all the time for excellence. And it's not, you can get really involved in it because it's like a family. And so yes, it is enjoyable, very much so.
Yeah, I must say, I mean, your leadership there has been transforming, really. It's not easy to lead a team of trustees. I think not many people realize how difficult it is. I mean, the job of being a trustee of these organizations isn't easy either. People that you don't get paid for it. It's a voluntary thing, and there's lots of politics swirling around, but you are very good at that. So what about the review of London hospitals? Because, I was a consultant at Bart's, consultant at St. George's. I was involved in when Maggie Thatcher tried to close down Bart's, and actually Tony Blair saved it in the end, and then it merged with the London. But tell us what happened with your role there of looking at London hospitals it was under the Blair government, wasn't it?
Yes, it was. Because Aradazi had been brought in to look at healthcare for London, and he wrote a big report on that. And then the whole area of managing London, it used to have a number of what do they call them? The health authorities. There were four health authorities in London, all condensed into one. And so he persuaded me to go and be the chair of the London Health Authority and institute this plan. But of course, again, it's the same old problem. Nobody wants to start to see mergers and involvement and getting together and doing things well. But I think one of the great things that came out of that were the hyperacute stroke centres, the cardiac centres, the trauma centres, and some degree of of pediatric work that was concentrated. But again, you know, that was all done in the Blair era. But when the Conservatives came to power in 2010, then Andrew Lansley killed that for some strange reason. And so it really did come to a grinding halt. And then the whole of the healthcare system was turned upside down again.
Yeah, it was sad, actually. I was telling you before that one of the things we did at the RSM, we had a congress after the terrorist atrocities, the one in London on London Bridge, where a whole load of people got stabbed, and the patients got sent mainly to King's, the trauma centre at King's. And in the same year, they had the explosion in the Manchester Arena, where the Ara Grande concert, where all the kids were severely injured, a load killed. What happened in London was that all those patients who were stabbed went to one trauma centre, King's, and every single patient that arrived at King's Trauma Centre survived. If they got there, they survived. And the police actually loaded the patients into the police cars and took them there rather than wait for the ambulances very bravely. Must have got a lot of blood over their seats, I'm sure. Whilst in Manchester, I mean, lovely people, but there was a problem. You know, there was a delay in getting into the arena because they thought another bomb might go off. So there were a load of injured people. And then I think even worse than that was they got just all these kids, they were mainly kids, teenagers, got distributed to every single hospital in Manchester. You know, some little hospital in the north of Manchester, another little hospital in the south of Manchester. There was no one trauma centre. So in these tiny places without experts, and I think a load of those children must have died or be mutilated because they weren't treated appropriately. So I mean, what you did, bring in these specialized centers, I mean, stroke centers, heart attack centers, and trauma centers, just three, was fantastic, really. And it was a shame that with the change of government that it wasn't continued, you know, because and also spun out of London, because the lesson in London is that it works. I mean, just mention what you said about Andrew Marr's stroke and the difference the centre made in his case.
He was rushed into Charing Cross, where the hyperacute stroke centre is, and you know, within 20 minutes you're treating him. And they've got all the kit. So they've got the thrombolytic technology, they've got CAT scanners, they've got everything there, the physiotherapists. So it's all set up to deal with the early period, which is so critically important in stroke. And it's just made an enormous difference in London. But if we go back in time when we were trying to put this in place, the opposition to doing that was quite remarkable, because the ambulance would take a patient to any one of 32 hospitals in London. And most of them had no CAT scanners, no thrombolytic technology, no special units at all, but they made a nice cup of tea. And that, you know, that was the attitude. And it took a lot of work to institute these new rules. And now you could look back and say, just how many lives have you saved by putting these trauma centres, hyperacute stroke centres, cardiac centres in place? Quite remarkable. And that's best practice. It should be everywhere. I don't understand why the NHS doesn't use best practice and just stick it everywhere, because that is the only way to go. We've got to have these specialist centres today to deal with specialist problems.
Well, we have quite a few. Often people from the media listen to these talks, so we might see something in the newspaper. Somebody's given me a note saying it's Ariana Grande. So it's typical. I'm an old fogey, so I don't know the names of these pop stars in the way that I should. So apologies for that. So let's come on to talk about the vaccine task force, Richard, because you know we had Kate Bingham on this program about 6 months ago, maybe a bit longer than that. And she did a fantastic job in the first wave, and then she disappeared off the scene. So give us some background to what the task force is doing now, and your thoughts about boosters.
So yes, Kate and the team did a brilliant job in getting the vaccines ordered, getting them set up. We were the first in the world to approve both the Pfizer vaccine and the Oxford vaccine first in the world to start vaccinating people with those vaccines. So it again just showed the power that we have in the UK, both in terms of regulatory authorities, the NHS, NHSI, NHSR, all the bodies came together, the academics came together, the industry came together, and everybody worked to do what was achieved. And now the big issue, of course, is making sure that we have resilience for the future. We've got the vaccines. We've got plenty of vaccine now to do the boosting, to treat young people, 15 to 17-year-olds. All that vaccine is there now, and for 2022. And the question will be, what happens after that? And we have got to make sure, and the Prime Minister has made it clear, he wants to see that we've got resilience in the UK, that we can respond, we can produce vaccines in the UK, particularly modern vaccines like the mRNA vaccines. And that's what the task force, a lot of that is going on now. Also, of course, donating vaccines to the world. We're committed by the end of this year to have delivered 30 million doses of vaccine through COVAX or through other routes into other countries. And we're committed by the middle of next year to have delivered 100 million doses of vaccine, and that is all on track. So that's all done through the VTF. So the VTF is still doing some great work, great civil servants in there, and you mustn't forget that they work in the background. They do an incredible job, work extremely hard, and I've been so impressed with the way that these people dedicate themselves to doing these tasks. And they often get forgotten, you know. People think, oh, they're in the background. These are the people that drive the machine. It's okay, people like me being in the front row, but they're the ones who do all the work, and they drive the whole process, and they deserve a lot.
Well, David Cochran says, how can professionals combat vaccine hesitancy? I mean, that kind of links into the issue about Facebook and social media. I mean, there is an awful lot of rubbish out there, isn't there, in the media?
Well, and it's frightening, and you and I know that the issue, because in our own little hospital, we have a number of people who are patient-facing who will not get vaccinated, and that's true throughout the NHS. At least now the government have made it mandatory in care homes, which I would think it's extremely dangerous to be in a care home with such vulnerable people and not have been vaccinated. So at least we're starting to move in the right direction. But, you know, this is bonkers that people can just refuse to be vaccinated. This is so crucial. We all know that in children. You have to make sure it's not for the individual child, it's for the community. And you need that herd immunity. Otherwise, we're in serious trouble. You cannot go to the school in the United States, for example, unless you've had BCG. You cannot act as a surgeon without having the hepatitis vaccinations. You know, all this stuff is mandatory. And therefore, but why are we still allowing people unvaccinated to be patient-facing in a care situation? It doesn't make any sense.
Yeah, you're absolutely right. Coming back to Imperial, I like this comment from Dr. Toe. I assume he's a doctor, and may or may not, he probably is. Dr. Toe says, you were a fantastic chairman of Imperial College Healthcare, and many of us are very grateful for your leadership. If you were to do this again, what would you do that was different to get redevelopment of our hospitals? I think that's an interesting question.
What would I do again? You know, remember that all the medical schools in London used to be part of the hospitals, and it was the Tomlinson report, wasn't it, in 1997, that said, look, you need to take the medical schools out of the hospitals and put them into the universities, because it's an education. It's not just a training, it's also an education. And so they were all divided up to Mary's, King's, UCL and Imperial. And Imperial Medical School was a bit rejected, if you like, because remember, Imperial used to be called the Imperial College of Science and Technology. It was all about physics and mathematics and engineering. They were the great subjects in Imperial. And when these medics came in 2000, or whenever it was, they were a bit like nomads. You know, what the hell are those people doing here? They're not real scientists. They're not. And it took quite a long time to get that relationship going, to make sure that the aeronautical engineers realized that the cardiac surgeons, they all had something in common, the mechanical engineers and the orthopedic surgeons. And all these people then started to realize we can all work together. We can actually work and do some really good work if we all start to work in a collaborative way. So we set up the Institute of Biomedical Engineering, for example, which put people together, medical people, scientists, you name it. And that was brilliant, because then that all brought them together. But just in terms of hospitals, you know, there's too much stuff, as you know, in West London, far too much stuff. The Westminster Hospital, why did we need Westminster Hospital? Was it needed? It's a beautiful hospital, but you have Charing Cross, you have Westminster, you've got all the other hospitals around, and there needs to be some consolidation. But is anybody capable of doing it? No, impossible, because there's no strong leadership, there's no drive to do this, and it's just allowed to go on and on. Pediatrics is a bit of a joke in West London. And it always will be, because nobody will make the decision to sort it out.
And by sorting it out, you mean basically by closing some units and bringing it together.
There should be one centre for paediatric. I mean, you're back to the hyperacute stroke centres again. There should be one paediatric centre in West London, instead of poor kids being shifted from Chelsea and Westminster to St Mary's, shifted from St Mary's into Chelsea and Westminster, because some can do this and some can do that, and some can do a bit of this and some can do a bit of that. You know, it just needs some consolidation, like a lot of things in the NHS.
But so you've worked in industry, and you've worked in certain relation to the NHS, and you've done a whole lot of stuff in charity and fundraising too. I mean, where does your heart lie, Richard? What's your proudest achievement, and where have you enjoyed most being kind of linked into?
So the guy who started Glaxo, it was a group of people, a family who lived in the East End of London in the 1890s, and they were advised by their physician to go and live in Australia because of the climate. And they moved from Australia to New Zealand, and that's how they got involved in milk. And they imported milk into the UK. Remember, Glaxo builds bonny babies. It was all about milk and putting vitamin D into milk. But the guy who ran it was a brilliant marketeer. And he set up the whole trade name of Glaxo, which is a mixture of lactose and galactose, which are the milk sugars. He was called Alec Nathan. And he had this wonderful turn of phrase. He said, "The greatest joy in my life is to go to work each day with a pleasurable sense of anticipation." And I just love that. And that's what I've done every day of my life, Roger, basically. I just get up and think, what the hell can I do today? So I don't look back and say, well, I didn't like that and I shouldn't have done this. And I just love doing it. And I loved working in Glaxo. I love working in Imperial. I love working in the various things I do. Otherwise, I wouldn't do them.
And what's been your most frustrating moment? I mean, you must have had some frustrations.
Yeah, of course you have frustrations, but you know, that's part of life, isn't it? You just get on with it and deal with it. And we all know that at the end of the day, everything is about people. You've got to get people motivated. You've got to get them involved. You've got to show leadership, critically important. And if there are problems, you've got to work your way through them, but you take people along with you. And you try not to, you know, if you go around upsetting people all the time, even in a university, you try not to upset the students, because it creates a bad situation. So you always try to accommodate them. And I think that is critically important as well. So,
have you got any tips for our audience? Because, I mean, I think one of the problems in medicine is there's a lack of leadership, and partly the NHS, because, I mean, there are arguments for having a sort of level playing field where all the consultants are at the same level. But if you don't have a leader of the team, often the team doesn't really know where to go. There's a lot of floundering around. So
yeah, but I think you know, and many people on this call today will know that you wouldn't do what you do today. You wouldn't create the NHS if you were starting again. I mean, it doesn't make any logical sense. Maybe it did in 1947, but it's, you know, it's evolved since 1947. sometimes in a good way, but sometimes in a bad way. And I do think that we ought to just evaluate the whole model, because it does devalue people. You know, how long does it take to become a good physician or a surgeon? You know, you're not going to be there until you're 30. In many other walks of life, by that age, you're in the front row. I mean, and sometimes you're treated like in a bad way. So I think that, you know, if you look at the Australian model, where 50% of medicine is public, 50% is private, we've got to come to terminology with the fact that you cannot keep running a business that runs solely on taxes, on taxpayers' money. It doesn't work. You know, it's costing 150 billion a year now to run this organization. It's the biggest company in the UK. We don't have a $150 billion company. And so somebody needs to break this thing up into sizable chunks and manage it properly, and have a plurality of funding rather than just rely on tax intake. Because, you know, we all know the tax intake is not going to be what it was for a long time. And so I do think that, you know, these people working in the hospitals are amazing. They do an incredible job. Do they really get compensated properly for that? Do they really get everything they should? I doubt it, because it is really a hell of a stressful job, to be honest with you. And I don't think many people understand that. So it does need a complete review from the beginning, understanding and saying, how should we really be funding healthcare and running it for the next 25 years? That's something that should be set up now, almost immediately. But it needs leadership to do that. And I'm not sure that politicians like ever to get too involved in things like that.
Yeah. So just pouring more money in, which is what's happening at the moment, isn't going to provide the solution. It's a bit of a sticking plaster, isn't it?
Yeah.
It's nearly 8 o'clock, Richard, so we better let you go and have your supper. Don't go awake. I've got a couple of announcements. I've already mentioned that we've got Jeremy Hunt, Right Honourable Jeremy Hunt, tomorrow. Claire Bainton, one of our trustees, is going to be asking him questions about what's really interesting, the parliamentary report on the COVID response. And actually, I've got a copy of Jeremy Farrar's book I've just been reading about, despite there's some shocking things in there. I recommend that to our readers. Then again, I've mentioned Dame Sally Davis, antimicrobial resistance. That's on the 23rd of November. There's a small fee for that, but I think it's going to be like a 2-hour session, really interesting. And we'll be talking about the things that you've been talking about, new antibiotics and maybe new antivirals, and the issue of the farmers putting in antibiotics in the feed stuff for their animals, and the doctors, hospital doctors and GPs prescribing too many antibiotics, et cetera, et cetera. And then on the 17th of November, we've got Dame Leslie Reagan. I love Dame Leslie. She's done In Conversation with us. She's one of our trustees, isn't she? At King Edward VII. She's absolutely great. She's giving the Darwin lecture on gender equality issues, and of course that's we could have discussed that, getting more women involved more deeply, and this, that, and the other. But it's a pretty hot topic. But Leslie's going to be talking about that in the Darwin lecture. That's in person as well as online, and that's at the RSM on the 17th of November. So Richard, listen, thank you so much. I think you've done an amazing job in so many areas in your life. So I'd like to take this opportunity to thank you, and thank you on behalf of the Royal Society of Medicine for taking part in this webinar, and wish you and your wife, whose name is
Janet.
I'm blocking on it. Janet, the same as my mother, Janet. Yes, I was thinking, oh my God. Yeah, Janet, a wonderful evening, and thank you so much for your participation. And we asked people to fill in the review of this, so do send your reviews in, and we'll pass them by Richard and let him know what you thought of him. Good night, everybody.
Thanks, Roger.
Bye.
Thank you. Bye.